Welcome to the Da Vinci Academy Histology video course. The entire video course is available on YouTube and covers all of the fundamental principles of histology and relevant cell biology. You can find all of the videos from the course by clicking the Histology playlist link in the description below, and then you can access the corresponding practice questions and histology lab videos by going to our website, which is also linked in the description below. Alright, so this is the second of the two lectures for the cardiovascular system, and in this lecture we're going to be covering the histology and function of the heart. So first, an overview. The heart is a 4-chamber muscular pump responsible for driving perfusion to the entire body. So the first of those 4 chambers are the right and left atria. So you have the right atrium here, and then the left atrium here, and then if we draw the heart down like this, you have the right ventricle and left ventricle. And the atria are responsible for receiving blood. So the right atrium will receive blood from the systemic circulation, so via the superior and inferior vena cava. So here you see the SVC in this diagram driving into the right atrium here. And then you have the inferior vena cava, which is taking blood that is coming from the lower half of the body up into the right atrium. And then the left atrium is receiving oxygenated blood via the pulmonary veins from the pulmonary circulation. And you can see that sort of behind here where the pulmonary veins would be coming into the left atrium. Then the blood will flow into the ventricles. And then from the ventricles are responsible for pumping blood out from the left ventricle to the systemic circulation through the aorta, as we show here. So here's the aorta here, coming from the left ventricle, and then the right ventricle will pump blood to the lungs via the pulmonary artery. And remember, arteries are A for away, as in they take blood away from the heart. Common misconception is that they're always carrying oxygenated blood. In the case of the pulmonary artery, that's just not true, because this is actually a point where maybe the most deoxygenated blood in the body is in the pulmonary arteries, because you're receiving all that deoxygenated blood from the systemic circulation. And then the pulmonary artery is responsible for carrying blood to the lungs where it receives oxygenation. Same thing with veins. Veins most of the time are carrying deoxygenated blood, but not in the case of the pulmonary veins. The pulmonary veins are probably carrying the blood with the highest concentration of oxygen because they're just coming from the lungs as they come back to the left atrium. So pumping occurs during 2 phases. You have systole and diastole. So remember, heart muscles is just like any other muscle. It contracts and it relaxes. So when the ventricles contract, that's during systole, and they're actively pumping blood into those pulmonary and systemic circulations. Then after they're done contracting, they relax, and that's during diastole, and that's when they receive blood from the atria. So as the ventricles relax, the atria contract and help move blood from the atria into the ventricles. Now, atrial contraction, it helps, but it's actually not the main driver of blood flow into the ventricles. The main driver of blood flow into the ventricle is actually a pressure gradient between the atria and the ventricles. And then during diastole, the pressure in the atria is actually higher than the pressure in the ventricle because you've just pumped out all that blood, you've just completed contraction, and they're relaxing. So they're relaxing, the pressure is going to be lower, and so the pressure in the ventricles being lower than the pressure in the atria helps drive that blood into the ventricles to fill them. The heart itself is perfused by the right and left coronary arteries, which branch from the aortic root. These are medium arteries, if you recall back to our blood vessel lecture. And if you see, you can see the right coronary artery here coming off the aortic root and perfusing the right side of the heart. And then the left coronary artery actually branches off behind the pulmonary artery here, and then it actually branches immediately. It's not a very long artery, into the left anterior descending artery, which is what you see here coming down kind of the midsection or left side of the heart here, and the left circumflex, which sort of wraps around the left side of the heart to the posterior aspect. And so those 2 arteries come off the left coronary artery. Now, histologically, there's 3 layers to the heart. If you start at the lumen, you have the endocardium, then you have the myocardium and the epicardium. So starting at the endocardium, this is the innermost layer, and it begins with the endothelium that faces the lumen of the cardiac chambers. So both the atria and the ventricles, just like a blood vessel lumen, are lined by endothelium. And this layer is actually analogous to the tunica intima of blood vessels. And so you can see that here. Here's your endothelial cells with your elongated, densely stained nuclei like this. And what you will also appreciate is that this is actually a very thin layer. So you have the endothelial cells, which if you recall is a specialized type of simple squamous epithelium. In the case of endothelium, they're bound by these tight junctions to help keep fluid in. And then just below the endothelium is a very thin layer of subendothelial connective tissue. So you can see that in here, and then you have some smooth muscle cells and some adipocytes in there. So the big thing from the endocardium is that it lines the chambers of the heart, and it has an endothelial layer. So the myocardium, this is the thickest and most functional layer of the three layers of the heart. This is where the cardiac muscle is. It has small amounts of connective tissue intermingled in. If you recall cardiac muscle, when we talked about it in the muscle lecture, it's kind of a branched network of muscle cells. And if you remember, those muscle cells are joined by intercalated discs. And if you remember, intercalated discs are these areas where you have a high density of both structural junctions and gap junctions, both to help securely attach muscle cells to each other, and then also to help with electrical conduction of the action potential, which is driving cardiac contraction. And then if you recall again, cardiac muscle cells, they typically have one, sometimes two nuclei. They're more round and densely stained. And then, as you know, their cardiac muscle is full of protein, so it's very richly staining in both kind of reddish or pinkish color, reflecting that eosinophilic stain of the protein within the cell. Myocardium is analogous to the tunica media of blood vessels. What's kind of an interesting fact is the capillary beds for the myocardium is actually within the endomysium, that connective tissue layer of the cardiac myocytes. And what's also interesting is that the Purkinje fibers, those specialized cardiac myocytes that help with carrying out cardiac conduction throughout the ventricles. If you recall, you have the SA node, which is in the right atrium, and then you have the atrial conduction fibers, and then they meet at the AV node, as we talked about in the cardiac muscle lecture. Then you have the bundle of His, and then you have the Purkinje fibers, which then help further propagate within the myocardium of the ventricles. And so these will travel kind of in the subendocardial layer. So you have the lumen, you have that endocardium here, and then you have the muscular layer like this, and just below the endocardial layer, you have these fibers, these Purkinje fibers, traveling in here. The outermost layer is the epicardium, and it's composed mainly of fibrous connective tissue with a little bit of adipose in there as well. This is analogous to the tunica adventitia of the blood vessel. You can see here, it's dense, irregular connective tissue. Here's the muscle layer, here's the myocardium, and then out in this region here, you can see a lot of different connective tissue here. Also traveling in here is autonomic nerves, which again, when they're innervating the actual conduction systems, especially the SA node, they can modulate the heart rate. And then when they're acting on the muscle, they can actually affect contractility, which is essentially the strength of contraction. You also have some vasovasorum in here to help provide perfusion to this outermost layer. And then what's interesting is that this epicardium is actually continuous with the visceral layer of the serous pericardium. So the pericardium, if you're not familiar with, is essentially a double layer, really triple layer connective tissue sac that encases the heart to help protect it. So if we draw the heart like this, so you have the epicardium, which is essentially this red line here. So this is the epicardium. Then you have what's continuous with the epicardium is the visceral layer of the serous pericardium. So we'll draw this layer here in black, which is essentially continuous with the epicardium. And then you have this outer layer here, which would be the parietal layer. So you have the parietal and the visceral layer like this. And together, these are the serous pericardium. And then the parietal layer is actually fused with the third layer of pericardium, which is the fibrous pericardium. Now, there's actually not this much space. This is just to kind of illustrate to you that they're between the parietal and visceral layers, there's what's called the pericardial space. Now, usually there's just a very thin layer of serous fluid in there. However, in pathological situations, you can have buildup of fluid or even blood in there. where you have buildup of fluid is like a pericardial effusion, and then where you have blood in there is actually what's called cardiac tamponade, which is actually can be fatal very quickly. That's something that needs to be treated really immediately, and so that's just something to be aware of. That's just a little bit of an anatomy tie-in. You'll get into more detail with this in your anatomy lectures. And then the last thing here is that the coronary arteries actually enter the cardiac tissue at the epicardium. So they enter outward and then dive deep through those 3 layers to provide perfusion to all 3 layers. And what's interesting is you have what's called a transmural myocardial infarction, where it actually affects all 3 layers. So if you have the endocardium like this, and then the myocardium like this, and then the epicardium out here. So if you have necrosis of all of these layers, that's a much more serious myocardial infarction or heart attack, because as you can see, it's affecting all 3 layers, versus a subendocardial is just affecting this area right here. And so that clinically, that's kind of a distinction that can be made is there's varying degrees of severity of a myocardial infarction, and a transmural is definitely much more severe. This is, if you're familiar with EKGs, would be a STEMI, which is where you'll see ST segment elevation on the EKG. And as you know, those are a definite emergency. As soon as those patients come in the door of the hospital, they are going up to the cath lab to get angioplasty and stenting done. So atrial myocytes actually have a unique appearance on EM, on electron microscopy. Unfortunately, we couldn't get a good image of that for you, so you'll have to maybe search around the internet. But functionally, they're actually smaller myocytes with fewer T-tubules, and then they actually have more numerous gap junctions to help generate a faster conduction rate than the ventricular myocytes. And then if you recall, let's draw our heart here. You have the SA node here, and then you have electrical conduction through the atrial myocytes, and they actually meet at this other node, the AV node here, which kind of slows down. So the rate of conduction is actually much higher in the atria, and the AV node kind of slows them down and helps time them up to make sure atrial contraction and ventricular contraction are coordinated to help with that both filling and then pumping, to help make sure that those are in perfect sequence so that you have the most efficient contractions possible. And so then from there you have the bundle of His, and then you have these Purkinje fibers, if you recall, that bring the electrical conduction throughout the ventricles. So these atrial myocytes, they actually have more numerous gap junctions to help create a higher rate of conduction throughout the atria. Now, what's interesting is that if you have volume overload, say in the setting of heart failure, where the heart's not pumping as efficiently, this can lead to the atria being stretched. And so when atrial myocytes are stretched, as we'll draw down here, so when you have fluid overload and you stretch the atria, what that does is actually trigger the release of brain natriuretic peptide, or BNP, which is a peptide hormone secreted from atrial myocytes. And what BNP does is a couple of physiological effects, because it's in response to volume overload. And so a physiological term for that is effective circulating volume, which is essentially intravascular volume. So if you have decreased effective circulating volume, that triggers the kidneys to actually release a molecule known as renin. And so renin is released by the kidney, and it triggers the synthesis of angiotensin II, which is a molecule that stimulates vasoconstriction of blood vessels. So that helps increase your blood pressure. Because if you decrease effective circulating volume, you're not perfusing as effectively. Angiotensin II then also leads to release of a hormone called aldosterone from the adrenal cortex. And what aldosterone does is it increases sodium reabsorption in the kidney. So where sodium goes, water follows, because it's a powerful osmolyte. And so again, all of these, by constricting your vessels, increasing sodium reabsorption, you're trying to increase effective circulating volume and increase blood pressure. Now, if you have volume overload, the opposite, Now, in response to that, BNP is going to do two things. One, it's going to inhibit the release of renin, so it's going to decrease vasoconstriction. The other thing it's going to do is inhibit the release of aldosterone. And so in turn, what that's going to do is increase urine output and then increase renal excretion of sodium. And so what these do is lead to a decrease in effective circulating volume and blood pressure. Now, in someone with heart failure, what happens is in heart failure is the heart doesn't pump as efficiently. The heart becomes significantly volume overloaded. And so as a result of that, you have serious stretching and you have significant output of BNP. And so it actually can be used as a clinical marker of heart failure. It's not necessarily diagnostic, but it's very, very common for a patient with volume overload heart failure to have a sky-high BNP on their labs. And so this is something that clinicians will always measure on somebody if they think they have heart failure. So one thing I'll briefly touch on is the cardiac skeleton, and it's in the name. It's a structural framework composed of dense, irregular connective tissue for the heart. It forms the fibrous annuli of the atrioventricular valves, which are the valves that separate the atria from the ventricles, as it is in their name. And so it forms a secure attachment point for the leaflets of the valve, which we'll talk about the structure of the valves in a second here. It also forms structural framework for the chambers of the heart as well, and to just serve as a support and to provide strength for the structure of the heart. The trigonal fibrosa is this kind of triangular shaped structure in the center here, at the center of the heart. And then you have the septum, which separates the different chambers of the heart, that has also majorly contributions from the cardiac skeleton. Cardiac valves, these are dynamic structures that regulate blood flow within and out of the heart. Structurally, they're avascular and they have connective tissue covered with endothelium. And so if you look at here, say the mitral valve, which separates the left atrium from the left ventricle. So if we draw this here, so as you can see, these would be the leaflets of the mitral valve. Mitral valve has two leaflets. And as you can see, the endothelium, which would be this red line here, extends out from the walls of the chambers to form these valves. And then you have connective tissue in here. And then you have the semilunar valves, which in cross section kind of look like this. And then if you were to pull these leaflets off of, they kind of have this semicircular shape like this, or semilunar shape like that, if you were to look down on these in a longitudinal section. And so that's where they get their name, semilunar. All four valves contain three essential subendothelial layers, essentially connective tissue layers. You have the fibrosa, which is dense, irregular connective tissue, spongiosa, which is loose connective tissue, and then ventricularis, which is dense, fibrous, and elastic connective tissue. So first, the atrioventricular valves. These are the mitral and the tricuspid valves. And their function is to prevent backflow of blood into the atria during ventricular contraction. And what helps them do that is that the leaflets are actually connected to papillary muscles, which are these muscles, as you can see here in this anatomical drawing, kind of outpouching from the ventricular wall, actually. And they're connected to these papillary muscles via these fibrous cords called chorda tendineae. They're described as strings on a parachute. So again, we'll draw this here for you. So here's the ventricular wall like this. Here's a valve leaflet like this. And we'll just say this is the left atrium. And then you have your papillary muscles like this, which again come off the walls of the ventricle. And then you have the chordae tendineae, which again are these kind of parachute strings attached to the leaflets, which we'll call, this would be the mitral valve here. So if you recall, during ventricular contraction, the ventricle is essentially squeezing the chamber here. It's squeezing this because if you remember from physics, pressure and volume are inversely related. When I say volume, I don't mean the blood volume, because this isn't entirely full of blood. There's still some space in here. What I mean is the volume of the chamber itself. And so during contraction, you're actually decreasing the volume because you're squeezing. It's essentially if you squeezed, a bag or some kind of container, you're squeezing the volume. You're decreasing the volume, and by doing that, you're increasing the pressure. It's like if you take an empty water bottle and twist it and twist it and twist it and squeeze it, eventually the cap pops off. That's because on the upper portion, you're decreasing the volume, and eventually there's so much pressure that it shoots the cap off. And it's the same thing here, because you want to generate a pressure gradient, because remember, fluid flows from a high pressure to a low pressure. So when the pressure in the left ventricle is greater than the pressure in the aorta, that's when the aortic valve opens, and that's when blood starts flowing out. And so the purpose of the atrioventricular valves is not to serve as a door to allow blood to flow in during diastolic filling. The purpose of these valves is to actually hold the ventricle shut to prevent any kind of backflow of fluid back into the atria. So the contraction, the pressure is so high in here that you need these papillary muscles contracting to essentially pull down on these strings and pull these valves shut, keep them from blowing out like this. And so you're keeping those valves shut and keeping a tight seal on the ventricular chamber. The order of the subendothelial connective tissue layers from atria to ventricles, so that means, atria would be at this point here, and then ventricle would be down here, and then the middle layer would be here. And sometimes these can show up on tests, so you want to pay attention to this. So for atrioventricular valves, it goes fibrosum, then spongiosum, and then ventricularis, so FSV. The ventricularis layer is actually continuous with the chorda tendineae. And then for semilunar valves, these are the aortic and pulmonic valves. These do not have chorda tendineae. They do not have papillary muscles. They open and close just relative to pressure gradients. Again, they serve to prevent backflow of blood from the aorta and pulmonary artery respectively. You can see them down here. So you have the pulmonary valve here, the aortic valve here. Again, they have that kind of star shape to them like this. And this is to prevent backflow during diastole. So again, let's take the aorta like this. You have the aortic valve like this. During diastole, remember, during systole, you're pumping blood out. You're expanding these out. This is during systole. And then remember, there's a lot of elastic tissue in the aorta, and so then it's going to recoil during diastole. Another pulse of blood shot out through the rest of the aorta to maintain continuous pulsatile flow. However, during this diastolic recoil, you don't want blood going back into the ventricle, and that's where the aortic valve comes in. Same thing happens in the pulmonary artery. And again, the order of these subendothelial connective tissue layers is spongiosum, fibrosum, and then ventricularis. So ventricularis is always last, and then you have SFV. And so again, this can sometimes show up on histology test questions, so you want to remember this order. Cardiac contraction, we'll just touch on this briefly again. Remember, we went over this in the cardiac muscle lecture. So cardiac contraction does not require neural input. It's actually generated from within, which makes it different from skeletal muscle, which relies on the neuromuscular junction. Remember, you have pacemaker myocytes, which are specialized cells that are able to generate action potentials and initiate contraction. So remember, you have the SA node here within the right atrium, and that is the pacemaker of the heart. And then you have action potentials traveling through those atrial myocytes, and then eventually they converge on the AV node, the atrioventricular node, which is shown here kind of at the junction between the atria and the ventricles. And remember, those atrial myocytes actually conduct action potentials at a higher rate than the ventricular myocytes. So the AV node essentially kind of, remember we talked about this, slows that conduction down to kind of help with the timing between the atria and the ventricles to make sure everything's done in sequence and in coordination. Then once leaving the AV node, they go through the bundle of His. So if we draw the AV node here, then you have the bundle of His that comes down like this, and then it fans out into these Purkinje fibers, which then also have these kind of tail ends to them like this. You can see that here to help further penetrate the myocardial tissue, thus carrying the conduction further into the tissue. And so these Purkinje fiber myocytes, they carry the action potential from the pacemaker cells into the myocardial myocytes via gap junctions at the intercalated discs. And remember that heart rate and contractility can be modulated by autonomic innervation, especially at the SA node. Now to close this lecture out, just a couple of quick clinical pearls for you. So angina, this is the clinical term for essentially chest pain, but it's not just any chest pain. It's chest pain that results from ischemia of heart tissue. So it's directly related to decreased blood flow to heart tissue. So remember, you have a normal, healthy coronary artery, and then you have the tissue here supplying, you have full blood flow. When you have underlying atherosclerosis, you have this buildup of these plaque here, you're limiting blood flow, not as much flow. You've limited the, remember, artery is just essentially a cylinder. You can't push as much blood flow through, and so you're not able to meet the O2 demand of the myocardium, and so by doing that, that leads to ischemia. And so, as we say here, the underlying atherosclerosis of the coronary vessels has progressed to the point of limiting perfusion of the myocardium. The key difference between this and a myocardial infarction or heart attack is that angina is a reversible injury. So sure, you have ischemia, but you haven't caused the myocardium to die off. And this can actually be mitigated with lifestyle changes such as quitting smoking, changing your diet, exercising, drug therapy like statins, which help lower cholesterol, blood pressure medications like aspirin that help prevent clotting, or to more invasive measures such as angioplasty and stenting. We'll talk more about that in a second, what that is. It's essentially sending a catheter with a balloon in here to kind of blow out these plaques and put a metal stent to hold the vessel open. Usually the pain is relieved with nitroglycerin, which is a vasodilator, which means that if you have constricted vessels, if you give nitroglycerin, it's going to open the vessels up. Now, you may think that's to help open up the coronary arteries, and it does that to a certain extent, but remember, you still have this blockage here. What that really does is, if you remember, you have the left ventricle like this, and then you have the aorta coming off like this, and then you have the systemic, circulation like this. What it does is it actually opens up the systemic circulation because the heart has to pump against, the resistance from not only the aortic valve and the aorta, but really the entire systemic circulation. So if you can open things up and maximize flow and decrease resistance throughout the entire body, you're going to decrease. If you decrease the resistance of the systemic circulation, you're going to decrease the O2 demand of the myocardium because the heart doesn't have to work as hard. If the systemic circulation is vasodilated and it doesn't create as much resistance, the heart doesn't have to work as hard. If the heart doesn't have to work as hard, it doesn't need as much oxygen. So what you're trying to do is what you have here is you have a mismatch between the amount of blood flow carrying oxygen you can provide to the high O2 demand of the myocardium. If you decrease that O2 demand, you're at least trying to meet the low perfusion halfway in a sense. You're trying to bring the level of O2 demand down to the point of where the limited perfusion from these atherosclerotic coronary vessels can at least be enough or almost enough that you're not causing damage and not causing symptoms. 3 types of angina. You have stable angina and unstable. These are the 2 most common. Principal is another one, but not as common as these 2. The big difference here is that stable angina is chest pain that occurs during exertion, but it's relieved with rest. So it hasn't progressed to the point where it's happening when you're not exerting yourself, because when you're exerting yourself, the exertion requires higher O2 because it just makes sense. If you're more active, if you're exercising or walking versus sitting down or sleeping, your heart needs to work harder. And so it means when you increase the demand, the O2 demand, the perfusion isn't enough. And so your disease, your amount of atherosclerosis, has progressed to the point where it's not enough, you don't have enough blood flow to meet the O2 demands of exertion. However, in unstable angina, you've progressed even further. You even have more serious disease to where you're having chest pain that occurs while resting. And so you barely even have enough perfusion to provide for the heart while at rest when you have like the lowest amount of O2 demand. Sometimes these patients, they have it so bad that they'll have chest pain in the middle of the night. It'll wake them up from their sleep. It's so bad. And if you're having chest pain from being asleep, that's the minimal amount of O2 demand. And so these patients, obviously, their disease is worse. They have a higher risk of progressing to myocardial infarction. And some of these patients will have kind of prophylactic interventions such as drug therapy, lifestyle changes, and then even sometimes they'll have angioplasty because a lot of times these patients will be the ones who end up in the emergency room. And then you have principal angina, which is episodic chest pain due to coronary vasospasms. So it's not due to atherosclerosis. You can certainly have atherosclerosis on top of these, but the actual pathogenic mechanism is that you have the tunica media, so this muscular layer in here, it contracts, which is what a vasospasm is. It's when the muscular layer of the artery contracts and then narrows the lumen. So you see on cross-section here, we've narrowed the lumen. It's the same concept, you're narrowing flow. See this very commonly in smokers, which can often trigger these vasospasms. So a myocardial infarction or a heart attack is when you have an atherosclerotic plaque that builds up within the tunica intima over time. So you have this plaque like this within the coronary arteries, and this plaque consists of lipids covered with a fibrous connective tissue cap. What happens is you have a rupture of this plaque. So you have all these contents within the plaque that then are released out into the vessel. That triggers clotting and buildup of platelets, and so then you form a clot within the vessel, which completely obstructs flow. You have complete occlusion, and this is what's called a thrombosis. And so you're blocking blood flow within the region, within the artery, and you're obstructing flow to the region supplied. And so what happens is over time, and you don't have a lot of time in this scenario, if the heart's not getting oxygen, then you're going to start going down the irreversible path of causing cardiac necrosis. And so the presentation for this is severe crushing mid-sternal chest pain. Sometimes it's just localized there. Sometimes it can radiate to the left arm. That's very classic or textbook. It can also radiate to the jaw. The treatment for this is you give morphine for the pain, you give oxygen, you give nitroglycerin like we talked about for the same reason in angina, to kind of offload the heart, cause decreased systemic resistance, decreasing the O2 demand on the heart. And then you give aspirin to decrease clotting. So MONA is the mnemonic for that. Then you do angioplasty and stenting. So angioplasty, so you have your clot like this, you have your plaque like this. You thread a catheter in like this, and you essentially have a balloon on here that you inflate inside of here. The thought is that you blast out the plaque, and then after you pull the catheter out, there's a metal stent or mesh on here outside of the balloon that gets left in here. And so it's a metal device like this that kind of has a scaffolding framework like this, and it helps hold the vessel open after you've blasted the plaque out. The other treatment is more traditional surgery, which is called coronary artery bypass grafting surgery. So let's say you have a blockage like this, you have very severe disease. This is typically typically used in patients that have very complex anatomy that isn't amenable to stenting, or they have multiple vessels, like 3 or more coronary vessels that require intervention. And so at that point, you have to do surgery. And so what the surgeon will do is they'll take the saphenous vein and they'll suture it proximal to the clot, to the coronary vessel, and then they'll bring it down here and then suture it down distal to the clot, providing essentially an alternate pathway or a bypass, as it is in the name, for blood flow. So blood flow is limited here, but guess what? It can get around the clot and then make its way back to supplying the cardiac tissue. And this can be a very effective surgery as well.
Thank you for watching this video from the Da Vinci Academy Histology video course, which is completely available on YouTube. To access the corresponding practice questions and histology lab videos, go to our website using the link in the description below.